Good morning, everyone. The topic of my presentation today is hallucination. I am Dr. Isha, MBBS intern. The topics that we'll cover today are definition, causes, hallucination of individual senses, special kinds of hallucination, hallucinatory syndromes, and the patient's attitude towards hallucination. Coming to the definition, hallucination is a false perception, which is not a sensory distortion or a misinterpretation, but which occurs at the same time as real perceptions. What distinguishes hallucination from true perception is that they come from within, although the subject reacts to them as if they were true perceptions coming from without. Now let us differentiate between perception, mental images, and pseudo-hallucination. So perceptions are basically substantial and appear in objective spaces. They are clearly delineated, constant, and independent of the will. Their sensory elements are usually full and fresh. Mental images, they're usually incomplete and are not clearly delineated and are dependent on the will and exist in subjective spaces. They are inconstant and have to be recreated. Pseudo-hallucinations are a type of mental image that, although clear and vivid, lack the substantiality of perceptions. They are seen in full consciousness, known to be not real perceptions. They usually occur in subjective spaces. Now, coming to the causes, we have 5 causes. Firstly, emotion, suggestion, disorders of the CNS, disorders of the peripheral sense organs, and sensory deprivation. So, firstly, emotions. Severely depressed patients may experience fragmented, critical voices such as "rotter" or "kill yourself," suggesting organic hallucinations. Suggestions. Researchers have shown that inducing hallucinations in healthy individuals is possible through methods like hypnosis or motivating tasks. Brief instructions such as asking the subject to envision animals or melodies can lead to visual or auditory hallucinations as well. Disorders of the CNS, lesions in the diencephalon and the cortex can produce hallucinations that are usually visual but also can be auditory. Then we have disorders of the peripheral sense organs. There is Charles-Bonnet syndrome, which we will discuss later. Then we come to sensory deprivation. Isolating a patient from external stimuli can lead to delusions and hallucination, which are characterized by repetitive words and visual distortions. Coming to classification, depending on the various parameters, firstly, we have the first parameter is sensory modality, which has various types such as auditory, visual, olfactory, gustatory, tactile, vestibular, and deep sensation. Depending on complexity, we have either simple or complex. Simple includes single sense modality, whereas complex includes multiple sensory modality. Now, depending on the organization, it is either unformed or formed. Unformed includes sparks of light or noises. Formed voices are basically the one that accuse the patient. Now, depending on reality value, they are either true or false hallucination. True hallucinations have reality value, whereas false hallucinations do not have reality value. Special types of hallucination will be discussed later. Hallucination of the individual senses. We have visual hallucinations, auditory hallucination, olfactory, pain and deep sensation, gustatory, tactile, and the sense of presence. So we'll elaborate on every hallucination for auditory hallucinations. They may be elementary and unformed and experienced as simple noises, bells, undifferentiated whispers, or voices. The voices sometimes gives instruction to the patient, who may or may not act upon them. These are termed as imperative hallucination. Then we have visual hallucination. These may be elementary in the form of flashes, partly organized in the form of patterns, or completely organized in the form of visions of people, objects, or animals. Occasionally, visual hallucinations occurs in the absence of any psychopathological or brain disease. Now we'll discuss about Charles-Bonnet syndrome. It was named after the 18th century Swiss scientist Charles Bonnet. It is a condition that causes people with decreased vision and various eye diseases to have visual hallucination. These hallucination can include seeing patterns or more complex images such as people, animals, and buildings. It is commonly seen in older patients. We have Lilliputian hallucination, in which the micropsia affects visual hallucination so that they see tiny objects of people. It is rarely seen in schizophrenia and also in case of Charles Bonnet syndrome. Then we come to tactile hallucination. Tactile hallucination is the false perception of tactile sensory input that creates a hallucinatory sensation of physical contact with an imaginary object. This may take the form of small animals crawling over the body, so-called formication, and this is not uncommon in active organic states. In cocaine psychosis, this type of hallucination commonly occurs together with delusions of persecution and is known as the cocaine bug. Since classified tactile hallucination into the following types: superficial kinesthetic effects that affects muscles and joints, and visceral, in which there is false perception of the visceral organs. Next, we have olfactory hallucination. Hallucinations of odor can occur in schizophrenia and organic states, and uncommonly in depressive psychosis. It may be difficult to be sure if there is a hallucination or an illusion. Sometimes the smell may be pleasant. For example, when some religious people can smell roses around certain saints. This is known as Padre Pio phenomena. Then next, we have gustatory hallucination, in which hallucination of taste occurs. And but it is not always easy to know whether the patient actually tastes something odd or if it is a delusional explanation of the effect of feeling. Then the various special types of hallucination are hypnagogic and hypnopompic hallucination, which is transitional hallucination that occurs during sleep, therefore hypnagogic, and awakening, that is hypnopompic. Then we have functional hallucination, in which perceptions without external stimuli, often associated with mental health condition, occurs. Then reflex hallucination, in which involuntary sensory experiences are triggered by external stimuli, often in neurological disorders. Then extracampine hallucinations are unusual sensory perceptions occurring in the absence of an external stimuli, potentially linked to certain neurological conditions. Then we have panoramic hallucinations, which are expansive and vivid hallucinatory experiences. Then we have autoscopy, in which self-perception or seeing one's body from an external perspective occurs. It is often associated with psychiatric conditions. Then let's discuss about hallucinatory syndromes. Hallucinosis refers to those disorders in which there are persistent hallucinations in any sensory modality in the absence of other psychotic features. It is divided into two types: alcoholic and organic. Alcoholic hallucinosis are usually auditory and occur during periods of relative abstinence. They may be threatening, although some patients report benign voices. They are associated with long-standing alcohol misuse. Organic hallucinosis are present in about 20 to 30% of the patients with dementia, and these are most commonly auditory or visual. Then the patient's attitude towards hallucination. In organic hallucination, the patient is usually terrified by the visual hallucinations and may try desperately to get away from them. Most delirious patients feel threatened and are generally suspicious. Impulsive attempts to escape from threatening situations may jeopardize their lives. The references that I took are from Fish, Clinical Pathology and Symptoms in the Mind. Thank you.
Good morning, everyone. Today I'll be presenting neurological examination in Parkinson's disease. So Parkinson's disease, as we already know, is a progressive movement disorder that occurs in old age, more than 60 years, and more often in male compared to female. So what is the pathophysiology related to it? It occurs basically because of degeneration of dopamine-producing neurons of substantia nigra pars compacta. So which leads to disbalance between the dopamine and acetylcholine and produces symptoms, movement symptoms, which you can remember as TRAP. T for tremors. Then we have rigidity, then akinesia or bradykinesia, and postural instability. And the therapy for it basically focuses on increasing the brain dopamine levels. Clinical symptoms, as already discussed, there are motor features. We have discussed TRAP, and then there are non-motor features which concern psychiatry, which is depression, anxiety, psychosis, sleep disturbances, dementia, etc. Now, CNS examination. Talking of CNS examination, we firstly, the prerequisite to it is knowing the handedness of patient and the education status so that we can assess the intelligence of the subject. So it begins with higher mental functions, which include comedies, consciousness, orientation, memory, emotion, mood, delusion, hallucination, intelligence, and speech. Then moving on to cranial nerve examination, motor systems, sensory system, reflexes, cerebral signs, gaits, and signs of meningeal irritation, and any obvious deformity of skull or spine. So since the very second year, we were taught to examine the patient right after the patient enters the clinician clinic. So we'll be going similarly with the case of Parkinson's disease. And for that, I would request my co-intern, Dr. Geshu, to act as a Parkinson's patient so that we can notice all the features that we are supposed to look for. So right now, she is acting as a 65-year-old female, and we'll be noticing any obvious deformities that we can already observe. Right now, we can see that there are resting tremors present in her hands, only in one side, that is asymmetrical. So asymmetrical resting tremors are features of Parkinson's disease. Then आप आ जाइए अम्मा. आ जाइए. Now we can see she's trying to initiate and she's having some problem initiating movements. So that is also a feature of Parkinson's disease. She's trying to walk, but it's taking her a while, and that's why she was nodding her head. As we can see, now we can notice her gait. It's short gaits. It's unlike ours, which is long stride. We walk with long strides. But on contrary to patient of Parkinson's, she's walking with short, shuffling gaits, and her reduced arm swing is noticed. There is no arm swing here. Right. Now, one thing that we also have observed, as you can see in picture also, there is comptocomia, which is abnormal thoracolumbar flexion more than 45 degrees. So there was a bend in her posture. She was screwed up forward, and that's what we have to observe in Parkinson's patient also. Now, Geshu obviously is young, so we won't be able to notice that. But Parkinson's patient, we also notice mask-like facies, which is fixity of facial expressions. There are no facial expressions in Parkinson's. In later stages, we can also observe soil flows because of drooling of saliva in Parkinson's patient. So resting tremors, as we have already seen, they were asymmetrical, and there are characteristic pill rolling movement as if a patient is rolling a pill in the hand. Then akinesia and bradykinesia. There is poverty or slowing of movements, which is a hallmark of Parkinson's disease. There was basically difficulty in initiating voluntary movements, as we saw while she was asked to come inside the room. She was nodding her head. Then there was reduced swinging. And when we ask of the complaints, like if we ask her, कि आप किस दिक्कत से आए हो, तो she will basically elicit history of difficulty in doing basic daily routines, and like, for example, tying buttons or shoelaces, etc. Now, akinesia and bradykinesia can be checked by thumb finger movement or fist open close test. So for that, I will ask patient to do things thumb finger open and close. We will ask patient to do it rapidly. So आपको ये जल्दी जल्दी करना, ठीक है? ऐसे. Now, for what we have to basically observe here is that the movements will become slower, and the amplitude of it will also decrease. So minimum 10 movements are required for it to elicit. We won't be like, अगर patient ने 4-5 किया हमें लगे कि normal है. We'll also make sure that more than 10 movements are done so that it's it. So we will notice that there is decrease in amplitude and speed of the patient of total. And similarly, if, for example, patient has osteoarthritis, it might be debilitating or painful for the patient. So other thing we can do is open close test. we can ask her कि आप जल्दी जल्दी ये करें. Okay. So similarly, at least 10 movements are required before she shows any slowing of the movement. Then in lower limb, we can do basically toe tapping. We can ask her to tap her toes. Jaldi jaldi करके. तो आपको ये जल्दी जल्दी करना है. So with patient, we'll see कि after more than 10 minutes, it will decrease. She'll try, but she won't be able to do it very fast. Now, talking of rigidity, rigidity again is a feature of Parkinson's, but it is not very obvious. Sometimes it might not be clinically observant. So we'll do some activating maneuver here. आप इसको ढीला छोड़ दो, मेरे हाथ में आप इसे रेस्ट करना है. तो पेशेंट का जो हैंड है, we should be able to feel its पूरा weight अपने hand पे. Then we'll check for any rigidity. Right now, I can't see any rigidity. So we'll ask for activating maneuver. आपको उस हाथ से इसे टैप करना है. ठीक है, वो 2 दिन की आपको लगे, बट जल्दी जल्दी करते रहना है. So after that, what we'll notice is there is some sort of rigidity. It will manifest later. So that is activating maneuver, and that's how we check rigidity. And similar can be done in lower limb as well. Yes, please. Ma'am, firstly we'll examine because it was not very obvious. So to activate it, we'll do activating maneuver, starting करनी है. Then after that, it will be obvious कि rigidity फिर manifest हो जाती है, तो we'll not be able to do it very easily. जो पहले easily movements हो रहे थे, then it won't be able to do. Then we have Mersenne signs, which we already saw. We were discussing in rounds as well. There was a sustained blink response. The glabular tap is basically a primitive response. So when we tap, we can see like normally we will blink our eyes, but this is for like 3, 4 blinks, and then after that we become acclimatized to it and we won't blink. But in patient of Parkinson's, this is sustained blink response, and that is called Mersenne signs, which is positive. Then there is hyperphonia. If we ask to talk, or if we talk to a Parkinson's patient, there will be stuttering and soft speech. And in later stages, there may be drooling of saliva and because of dysphagia component, which can lead to aspiration pneumonia as a terminal event. Then there is micrographia, as you can see in the picture, the progressive shortening of the letters while the patient is writing. The patient may also complain कि मेरे checks bounce होने लगे हैं. पहले they used to be accepted. अब मैं छोटे साइन कर रहा हूँ तो बैंक वाले चेक्स एक्सेप्ट नहीं करते. Then there was postural instability which can be assessed by pull test. I'll just demonstrate to you. Pull test basically normal for postural instability will pull the patient back, and they that should be explained for normal जैसे होता है, so she'll be able to maintain her posture. But later with Parkinson's patients, when we pull, they won't be able to maintain the posture, so they will fall back. So to avoid any fall, because obviously the clinician can also fall, so to avoid that, the prerequisite of caution is that you stand in front of a wall. So even if a patient falls on you, you're better supported with a wall. So for a normal patient, when we pull, she was able to maintain her posture. She took 1 or 2 steps and then she was able to maintain. Now in Parkinson's patient, when we pull it, she will directly fall in. So because we had walls, so it was a caution to avoid any mishap. Then we have anosmia, which we will notice in cranial nerve 1 examination. Patient won't be able to smell things properly. And then gait abnormalities, as we had already observed, there was shuffling gait and absent downswing. Then there are cognitive and psychiatric changes, dementia, depression, sleep disturbances, or anxiety. Based on our examination, we can stage the Parkinson's disease. If only one side of the body is affected, that is stage 1. If both sides of the body is affected, that is stage 2. And if the balance and stability become affected, that is stage 3. And if symptoms increase, but patient is able to walk, that is stage 4. But if assistance is required for everyday activity, that is stage 5. So take home message. Muhammad Ali, as you can see in a picture, was a very famous American boxer who died with Parkinson's disease due to pneumonia. So the possible hypothesis was because of the frequent blows because he did not wear protective gears to head while fighting. There was microvascular injury which might have accumulated in basal ganglia and manifested it as Parkinson's disease. So Parkinson's disease is a movement disorder which occurs in old age and can occur in youngs as well. Example, Muhammad Ali. Parkinson's disease is mostly diagnosed clinically, and hence it's become very important to elicit clinical history and examine patient properly, which plays a pivotal role in improving the quality of life if we initiate the treatment early. Then as psychiatrists, we have to keep in mind that all the antipsychotic uh, drugs can also give Parkinson's-like feature, and drugs can cause psychotic activities. So that is something we have to keep in mind and be watchful of the same. These were my references.
Good morning, everyone. I am here to present the topic tremors and examination. My moderator is Dr. Ramesh. Tremors. Tremors are hyperkinetic disorder. It is the most common movement disorder encountered in clinical practice. Tremors is called rhythmic oscillation of a body part due to intermittent muscle contractions of the antagonist and agonist muscles. It is repetitive movements of regular frequency and amplitude. Tremors can be classified according to distribution, frequency, etiology, and related neurological dysfunction. Types of tremors. First, resting tremors. Second, action tremors. Third, postural tremors. Kinetic tremors. Resting tremors are found in Parkinson's disease. Action tremors and postural tremors are found and kinetic tremors are in cerebral disorders. Physiological tremors. These are found in normal individuals. They are mild, high-frequency postural or action tremors, upper limbs. Also, enhanced physical tremors can affect 10% of the population, found in anxiety, fatigue, metabolic disturbances like hyperthyroidism, dyselectrolytemia, drugs like valproate, lithium, thyroxine, nifedipine, and toxins like caffeine, alcohol, smoking. Parkinson's disease tremors. These are resting tremors of medium frequency. They begin unilaterally, first distally from digits and wrists like pill rolling tremors. Like this, next and thumb are rolling on themselves. They spread proximally ipsilateral and occasionally to legs before crossing to the contralateral side. Later stages, they involve lips, tongue, and jaw, but never involve head and neck. Essential tremors. These are the most common type, affecting 5% of population, can be present even in childhood, but increase dramatically after 70 years of age. These are postural or action tremors. They are high frequency and affecting upper limbs. They are bilateral and involve symmetric. In severe cases, can interfere with functions like eating and drinking. They involve head in about 30%, patient's voice about 20%, and tongue in 20%. They are worsened by stress but improved dramatically by alcohol. In these, neurological examination is normal. Here's the difference between essential tremors and Parkinson tremors. In Parkinson's tremor, at rest increase with walking and decrease with posture holding or action. But in essential tremors, tremors are due to posture holding or action. Frequency is in this low 3 to 6 hertz and this is high 5 to 12 hertz. Distribution in this is it asymmetrical, and essential tremors have symmetrical distribution. Body parts involved are hands and leg in Parkinson's tremors, and essential tremors, these are hands, head, voice, tongue. In writing, the Parkinson tremor, in Parkinson disease, people write small and illegible, micrographia. And essential tremors, they write large words, tremulous, and macrographia. The course of illness in Parkinson disease, it is progressive, and essential tremors, it is slowly, yeah, stable. A family history, Parkinson disease family history is less common. Essential tremor have great family history, long family history. Other neurological signs, Parkinson disease have bradykinesia, rigidity, loss of postural reflexes, या akinesia. Essential tremors, no other neurological signs are present. Substances that improve tremor. Parkinson's disease, the drug levodopa and anticholinergic. In alcohol, in essential tremors, alcohol, propanol, and primidone are effective. Surgical treatment. Patients of Parkinson's disease usually have other symptoms like bradykinesia and require subthalamic nucleus or internal globulus pallidus deep brain stimulus. And in essential tremors, they require thalamic VIM, DBS, or thalamotomy. In examination, consent is taken before examination. Patient is asked to sit on a comfortable chair in front of the examiner. The vitals are taken like like temperature, respiratory rate, blood pressure, and BP. Hyperthermia, tachycardia, tachypnea can be present as a part of anxiety or high fever, या फिर hyperthyroidism. A general physical examination, pallor-rectus clubbing, cyanosis, lymphadenopathy, edema is seen. These are usually normal. Head-to-toe examination is done to note any remarkable signs like posture in Parkinson disease, resting tremors also in Parkinson disease, facial masking Parkinson, eye changes, neck swelling like respiratory system usually within normal limits, cardiovascular system usually within normal limits, abdomen within normal limits, genitourinary system within normal limits. Neuromuscular examination. Patients are usually oriented to time, place, and person. In essential tremors, bilateral action tremor are found affecting hands and forearm, and other neurological signs are absent. Parkinson disease, foveal rigidity is found, bradykinesia. Yes. Alcohol-induced tremor, we do finger to nose test. The patient is asked to move his fingers from the periphery to his nose, and he is unable to do in a well manner. Cerebral tremors. Cerebral function के लिए. Also, cerebral tremor, finger to nose test. Sir, extremities, ask the patient to pronote. Sir, first the patient ask the patient to उनके हैंड की आगे करो और फिर हम उनके रेस्टिंग टाइमर्स देखेंगे, और सर फिर हम उनको पुट करने के लिए यहाँ बोलेंगे, और उसके बाद पार्किंसन में हम उनको बोलेंगे कि थंब ऊपर करो और लिटिल फिंगर डाउन करो, तब भी वो उसमें ट्रेमर्स दिखेंगे. और पेशेंट्स को हम यूँ कह सकते हैं कि आउटस्ट्रेच करो अपने हैंड, तब भी ट्रेमर दिखते हैं, और ग्लास में से पानी पिएगा तब भी उसके हैंड शेक होंगे. In the here in the photo we can see rest tremors and the action tremors. And the second test is spiral test. We ask the patient to draw a spiral, and the normal subject can draw the spiral easily. Parkinson disease, in the Parkinson patient, he draw a very small circle. Essential tremors, spiral ढंग से नहीं कर पाएगा और उसमें बहुत ज्यादा हाथ लगेगा. References Harrison Principle of Internal Medicine and Hutchinson Clinical Methods. Thank you.
Good morning, everyone. Today's presentation is serotonin and its relevance in psychiatry. And my moderator is Dr. Sanjeev. This is an overview of the topics that we will be going through today. First, there will be an introduction, then synthesis of serotonin, domination of action, serotonin receptors, serotonin and psychiatric illnesses, and finally we'll talk about the pharmacology. For serotonin, which is better known as 5-hydroxytryptamine, it is a monoamine neurotransmitter, and the cell bodies of the serotonergic neurons, they are clustered in midline raphe nuclei of brainstem. The rostral raphe nuclei sends ascending axonal projections throughout the brain, whereas the descending caudal raphe nuclei sends projections into the medulla, cerebellum, and spinal. The central nervous system, it contains less than 2% of the serotonin in the body, and peripheral serotonin is located in platelets, mast cells, and enterochromatin cells. And more than 80% of all the serotonin in the body is found in the gastrointestinal system, where it modulates motility and digestive functions. Now, this is the diagram which shows the synthesis of serotonin. First, tryptophan, it is taken into the cell via the tryptophan transporter. Then tryptophan, it is converted into 5-hydroxytryptophan via aromatic amino acid decarboxylase, and then it goes into the synaptic vesicles via VMAT2 transporter, and it will stay there till a neuronal impulse occurs. Now, serotonin, it is destroyed mainly via MAO-B. It is again uptake occurs via serotonin transporter, and then MAO-B, it destroys serotonin only when it is in high concentrations. Now we talk about serotonin receptors. Now there are many receptors, but the main ones are your 5-HT1A, 1B, 1D, 1E, 1F. There is 5-HT2A, 5-HT2B, 5-HT2C, 5-HT3, 5-HT4, 5-HT5, 6, and 7. Now 5-HT1, it mainly there is inhibition of adenyl cyclase, and there is increase in G protein activity inwardly rectifying potassium. And its clinical relevances, they are partial agonists like buspirone. It is an anxiolytic. There is role in hippocampal neurogenesis. Then in 5-HT1B or 1D antagonists, they are also used in as anti-migraine agents. We use them as triptans. Then 5-HT2A, 2B, and 2C, they increase phosphainositide specific phospholipase. And their antagonists, 5-2A antagonists, they have antipsychotic effects. 5-HT2A agonists, they are your hallucinogens. 5-HT2B agonism is involved in cardiac valvulopathy. And 5-HT2C agonists, they are currently under development as anorexogens and antiepileptics. 5-HT3, it works by sodium channel cell membrane depolarization, and its agonists like ondansetron, they are used as antiemetics. 5-HT24, it again increases adenyl cyclase. Its partial agonists are used in IBS like pegaserot, and 5-HT5, 6, and 7. They are also increased. They also increase adenyl cyclase. Their clinical relevance currently is unclear, but antagonists, it may have antidepressant. Now, in psychiatric illnesses, first we will talk about serotonin and its effect in psychosis. There is a serotonin hypothesis of psychosis and schizophrenia, which says that hyperactivity or imbalance of the serotonin activity, particularly at serotonin 5-HT2A receptors, it results in psychosis. In this, we talk about Parkinson's psychosis. Now we know that in Parkinson, there is loss of serotonergic neurons, which project from the raphe nucleus to the prefrontal cortex. Now, this will cause upregulation of 5-HT2A receptors. Now, overstimulation of these 5-HT2A receptors, it will cause excessive glutaminergic release. And it will cause your effects like delusions and auditory hallucinations. Excitation of glutaminergic receptors in visual cortex also cause visual hallucinations and Parkinson's. Second is psychosis in dementia. Now, we know that dementia, there may be accumulation of plaques or tangles or cases of stroke or Lewy bodies may be present. Now, they destroy some glutaminergic, so they will cause some loss of normal GABA inhibition, which occurs by neurodegeneration occurs in this. So again, 5-HT2A, it will be overexcited, and because normally it is balanced by GABA inhibition. So this will again cause increased glutaminergic, increased glutamate excitation, mesolimbic dopamine hyperactivity will occur. Again, delusions and hallucinations will occur, and overstimulation in the visual cortex will cause visual stimulations. So glutaminergic hyperactivity. Second is, sir, in mood disorders. First is, we have a monoamine hypothesis of depression. This is the classical theory about biological etiology of depression, which hypothesizes that depression is due to a deficiency of monoamine neurotransmission. And it says that mania may be, the cause of mania may be the opposite. That is, there may be an excess of monoamine neurotransmission. Next was neurotransmitter receptor hypothesis of depression, which said that an abnormality in the receptors for monoamine neurotransmitters, it leads to depression. And the depletion of neurotransmitter causes compensatory upregulation of postsynaptic neurotransmitter receptors. So synapses. Now, this diagram, it shows the monoreceptor. First, it states the monoamine theory of depression, which states that in the normal state, where when the quantity of dopamine or dopamine, norepinephrine, and serotonin, it is in the normal levels, there is no depression. Depression is caused by deficiency of monoamine, and monoamine theory. The receptor hypothesis of depression says that the receptors will now upregulate due to the lack of monoamines. Now, in anxiety disorders, the three major neurotransmitters which are associated with anxiety on the basis of animal studies and responses to drug treatment are norepinephrine, serotonin, and GABA. Now, different types of acute stress will result in an increased 5-hydroxytryptamine turnover in the prefrontal cortex, nucleus accumbens, amygdala, and meatrial hypothalamus. Now, serotonin, it is a key neurotransmitter which innervates the amygdala as well as all elements of CSTC surveillance, namely your prefrontal cortex, striatum, thalamus, and thus it is poised to regulate both the symptoms of fear and worry. Next is serotonin and pain. Now, descending inhibition, mostly via serotonin and noradrenergic pathway. It's normally active at rest and is thought to act physiologically to mask perception of irrelevant nociceptive input, like from digestion or joint movement. Now, one hypothesis for why patients with depression or fibromyalgia or related chronic pain disorders perceive pain when there is no obvious sign of peripheral trauma is that the descending inhibition may not be acting adequately to mask irrelevant nociceptivity, which leads to the perception of pain from what is actually normal input, which normally it is ignored. Now, in this diagram, as we can see that when the descending serotonergic pathway, it is normal in function, the patient, he will not feel any pain, which there is masking of pain from the, but when there is deficient 5-HT inhibition, it will it will prevent, it will cause the bodily input, which normally gets inhibited. It reaches the brain, and then the patient proceeds with aspirin. Now, serotonin and sleep wake cycle. Now, serotonin, it has a function in wakefulness. Now, there is release of serotonin from raphe nucleus into the basal forebrain and thalamus, and orexin and hypocretin. It is also hypothesized to stabilize wakefulness through its effect on serotonergic function, among others. Next is on substance addiction. Now, hallucinogens and MDMA. These are the two substances which are hypothesized that they also affect serotonin. They also affect serotonin. Now, the the MDMA, which is a synthetic amphetamine, it acts more on serotonergic, it acts more on SERT transporter rather than dopamine transporter, and there is competitive inhibition. It acts as a competitive inhibitor and a pseudo substrate at SERT. So it blocks serotonin from binding. And there is also, and so there is displacement of serotonin, and reuptake of serotonin does not happen. Then it also, there is also competitive inhibition of VMAT, and at high levels, there is displacement of serotonin into the from the synaptic vesicles into the terminals. And once a critical level is reached, there is dumping of serotonin into the into the terminals. So MDMA, it acts on serotonin receptor. Yes, sir. So, sir, serotonin reuptake will not happen. So, sir, यहाँ पे सर ऐसे सर टर्मिनल्स में सेरोटोनिन ऐसे इंक्रीज होता है. Yes, sir. Yes, sir. Yes, sir. And then, sir, in second, जो VMAT ट्रांसपोर्टर होता है, जो सेरोटोनिन को सिनेप्टिक वेसिकल्स में रखता है, सर उसका भी कॉम्पिटिटिव इनहिबिटर होता है ये. एंड सर उसके साथ साथ सर डिस्प्लेसमेंट, सर उसमें सर सेरोटोनिन सर उसमें वहां पे नहीं जाएगा, वेसिकल्स में नहीं जाएगा. एंड सर उसमें सर एक वो सबस्ट्रेट की तरह भी एक्ट करते हैं सर. वो भी सर उसमें जो MDMA होता है वो भी वो आ जाता है वेसिकल्स में. यस सर. यस सर. तो सर जब एक एट अ क्रिटिकल पॉइंट सर डंपिंग हो जाती है सेरोटोनिन की इनटू द टर्मिनल्स. सर ऐसे सर इफेक्ट आते हैं. Next is hallucinogen psychosis. Now, hallucinogens, which are, for example, your LSD, now they again stimulate your 5-HT2A receptors and excite the glutamate receptors. And this again will cause hyperactivity, delusions and hallucinations, and in the visual cortex will cause visual hallucinations. Now, in obsessive compulsive disorder, now several research groups, they have hypothesized that the therapeutic actions of SSRIs in OCD, they involve dampening of activity in hyperactive orbitofrontal subcortical circuits, which drive your obsessive compulsive behavior, and they possibly restore balance between direct and indirect frontal cortical pathways. Now, serotonergic neurons, which originate in the brainstem, they include projections to the orbitofrontal cortex and ventral striatum. These are the two brain regions implicated in pathophysiology of OCD.
However, this is just a hypothesis, and it's not and proper clinical case trials. They have not found anything definite. Now, in eating disorders, now data from DC and clinical neuroscience studies, both in animals and humans, they have uncovered the role of serotonin in essential mechanisms of eating disorders, such as feeding, fasting, and satiety. It was also shown to have a role in body image and perception abnormalities observed in patients with eating disorders, as well as other related characteristics, including seasonality of symptoms, prevalence in females, and onset after stressful life events. And it was also related to the psychiatric traits associated with eating disorders, such as depression, anxiety, impulsivity, and addiction. Now, pharmacology. According to the receptors, now 5-HT1A, it acts as a partial agonist. The drugs which act on it are buspirone and ipsapiron, and it is used in anxiety and depression. 5-HT, it is an agonist. Sumatriptan, sumatriptan works on 5-HT1D and it is useful in migraine. 5-HT2A, 2C, they are antagonists. The drugs which act on them are methotrexate, risperidone, and ketanserin, and they can be used. And the clinical disorder which they are used are migraine, depression, schizophrenia. 5-HT3 antagonist is ondansetron, which is used in chemotherapy-induced NSS. 5-HT4 agonist is cisapride, which is used in GI disorders. And SERT inhibitor is fluoxetine and sertraline, which is used in depression, OCD, panic disorder, social phobia, among others. Now, first, we will mention about selective serotonin norepinephrine reuptake inhibitors, which includes venlafaxine, desvenlafaxine, duloxetine, levomilnacipran, and milnacipran. And the therapeutic effect of these medications, they are mediated by concomitant blockade of 5-HT and norepinephrine reuptake transporters. They are also sometimes referred to as reuptake inhibitors. Next is selective serotonin reuptake inhibitors. They work by selective and potent inhibition of serotonin reuptake. And although the action of SSRI as a presynaptic axon terminal has classically been emphasized, it now appears that the events which occur at the somatodendritic end, it may be more important in explaining the therapeutic actions of SSRIs. Now, this is a table which shows the selective serotonin reuptake inhibitors and the currently approved indications in the United States. Now, citalopram, it is indicated for major depressive disorder. Escitalopram is for major depressive disorder and generalized anxiety disorder. Fluoxetine is for major depressive disorder, OCD, panic disorder, social anxiety disorder, bulimia nervosa, and premenstrual dysphoric disorder. Fluvoxamine is for OCD in both adult and pediatric. Paroxetine is for major depressive disorder, generalized anxiety disorder, OCD, panic disorder, PTSD, social anxiety disorder, and premenstrual dysphoric disorder. Sertraline is for major depressive disorder, OCD, panic disorder, PTSD, social anxiety, and premenstrual dysphoric disorder. And vilazodone is for major depressive. Here we mentioned serotonin syndrome. Now, concurrent administration of an SSRI with a MAO inhibitor, L-tryptophan or lithium, it can raise plasma serotonin concentrations to toxic levels, producing a constellation of symptoms which are called as serotonin syndrome. Now, the serious and possibly fatal syndrome of serotonin overstimulation comprises, and this is in order of appearance as the condition listed. First, there will be diarrhea, then restlessness, extreme agitation, hyperreflexia, and autonomic stability with possible rapid fluctuations in vital signs. There may be myoclonus, seizures, hyperthermia, uncontrollable shivering and rigidity. Then delirium, coma, status epilepticus, cardiovascular collapse, and even death. Now, treatment consists of removing the offending agents and promptly instituting comprehensive supportive care with nitroglycerin, cyproheptadine, methysergide, cooling blankets, chlorpromazine, dantrolene, benzodiazepines, anticonvulsants, mechanical ventilation, and paralyzing agents. Next is serotonin dopamine antagonists. Now they have an effect on both dopamine and serotonin systems, and And individual drugs in this group, they have multiple neurotransmitter effects. Now, as of 2013, 10-second generation antipsychotic drugs were approved by the FDA, which includes risperidone. There is risperidone iron long-acting, olanzapine for extended release injectable suspension, quetiapine, ziprasidone, aripiprazole, paliperidone palmitate, sanapine, lurasidone, iloperidone, and clozapine. Now, busspiron acts on two receptors, serotonin and dopamine. It has high affinity for 5-HT1A serotonin receptor, acting as an agonist or partial agonist, and moderate affinity for D2 dopamine receptor, acting both there as an agonist and antagonist. And its approved indication is in treatment of generalized anxiety disorders. And to make a mention of serotonin and ECT, various research studies, they have reported an increase in postsynaptic serotonin receptors, or sometimes even no change in serotonin receptors, and a change in the synaptic regulation of serotonin. These are my references.